So I think we can start. A very warm welcome to our webinar on hepatitis C treatment, and a very warm welcome to Jürgen Rockstroh, who will be holding this webinar. My name is Christian Jachnovich. I work as EATG training coordinator, and I will moderate during the next hour. This webinar is organized in the context of the EATG project HAND, which stands for Hepatitis Access Needs. And I added the slides so that you can already save the date for two other webinars on hepatitis. Hepatitis B treatment webinar, which will be organized on the 18th September, also between 3 and 4 Central European time. And hepatitis prevention webinar, which will be organized on 16th October 2017, between 3 and 4:30 Central European time. This webinar, as well as the other webinars, will be recorded, and we will upload the recording on our training website, which is www.eatgtrainingacademy.com. We will upload the recording probably in a couple of days, and I will notify you about that. Before Jürgen starts, I just would like to tell you about questions. So you can write your questions under the question field. You can see it in your interface, or you can raise your hand. So then I see that you have raised your hand, and I can unmute you so that you can address your question by speaking into the microphone. After Jürgen's presentation, we will have a room for 15 to 20 minutes Q&A, and then you can raise your questions. Okay, Jürgen, thank you very much for your support in organizing this webinar, and the floor is yours.
All right, well, thank you very much for the kind introduction, and if we move to the next slide, you'll see my conflict of interest. And with that being said, I think we're going to start off with our first issues around hepatitis. If you move on to the next slide, we'll start with epidemiology. And the next slide, I think, shows you nicely some of the more recent work which was published in The Lancet, looking at the leading causes of mortality and trends. And they look at two observation time points, 1990 and 2013. And you can see that people dying from viral hepatitis have made it to the 7th most prominent cause of death. So among all infectious diseases, viral hepatitis accounts for most people dying as an underlying disease, really highlighting the importance and why we need treatment in that area so urgently. So what I want to do in the next 40 minutes or so is really walk with you through some of the aspects of epidemiology. How many patients do we have? How do we get infected? Which groups do we have to care for? What are the issues around the natural course of hepatitis C, who gets sick, who develops liver cancer, how does that change in the setting of HIV, talk a little bit about treatment strategy, some of the new drugs, then also about issues during therapy, hepatitis B reactivation, risk of reinfection, and other things. And then hopefully, if it has not been touched upon, if there are remaining other questions, I'm very happy to address that in the Q&A section. Next slide. Now, the first important thing to look at from an epidemiology standpoint, next slide. Oh yeah, so the overall number of deaths is 1.45 million per year through viral hepatitis. So clearly a huge clinical need to take care of these diseases. Next slide. Now, I think one of the important things when you look at various textbooks or review articles, you always see completely different numbers or estimates of global number of hepatitis C infections. And a lot has to do with that. When you have hepatitis C, you may actually clear your infection spontaneously. So just having antibodies means that you either had hepatitis C or you may still have hepatitis C, but only in the presence of antibodies and having detectable virus, which we call HCV RNA, do we have ongoing replicating hepatitis C, which we then consider chronic hepatitis C, if that is present for more than 6 months. And you can see here, if you only look at the ones which have viremia, then only there is an estimate of 80 million people worldwide, whereas if you look at antibodies, the number of infected becomes much higher with 115 million. But obviously people who only have antibodies need no treatments, only the ones with chronic hepatitis C and signs of replication would require therapy. So it's important that the number of people may be different than initially estimated. And that's important because it means we need much less money than initially thought for treating and potentially eliminating hepatitis C from this globus. Next slide, please. Now, obviously, transmission pathways for HIV and hepatitis C overlap. So of the 37 million HIV infected worldwide, we believe that 2.3 also have hepatitis C. You can see that this is particularly enriched in patients with intravenous drug use, and obviously using of infected syringes is probably the most prominent way of getting hepatitis C, and so no wonder over 80% of all intravenous drug users with HIV also are believed to have HCV. You can also see from the global map that this occurs everywhere in the world, telling us again and reminding us that access to hepatitis C drugs should be everywhere, not only in Europe and North America, but in every continent affected, because patients are everywhere in this world. The amount of heterosexuals with HIV and HCV is much smaller, and there is a rising outbreak of acute hepatitis C among MSM with increasing prevalences of co-infection. Next slide. The risk of hepatitis C infection also varies between populations, between HIV positive and HIV negative, and you can see that there's a particularly higher risk now in the MSM, so men who have sex with men community, but in particular in the setting for prisoners, and that has a lot to do with that prisoners have difficult access to clean syringes, and so there is a very high probability of when you use drugs in prisons intravenously that you will be using something which is contaminated and may lead to transmission of hepatitis C. Next slide, please. The outbreak of hepatitis C among HIV-positive MSM was described for the first time in 2002 in London. Subsequently, in large European cities with large gay communities, like Berlin, Amsterdam, and Paris, have also reported outbreaks, quite a number of cases. This map captures all published cases, so this is not a true estimate of how many people had acute hepatitis C in the setting of having HIV and being MSM. It's just those who were reported, so the numbers of true cases is probably much higher. But I think one of the fascinating things here is that something which started in Europe has now occurred in many different places in the world, and since these viruses are not phylogenetically necessarily related, also tells us that this has happened at pretty similar time points in various places with different viruses. So something has changed in the community which has led to the spread, and now also involves Asia, Australia, and North America, but an increasing number of European countries as well. Next slide. Now, one of the big questions is, obviously, since this is particularly prone in the HIV positive MSM patient population, the question became, well, are we also going to see this in HIV negative MSM? And obviously, that is much more difficult to assess because there are not so many clinics which cater HIV negative MSM. But now with PrEP on the horizon and PrEP projects being implemented in various countries, we do have a chance to do hepatitis C screening in patients who present for PrEP use. And you can see here from one of the first studies in that particular patient population from the Netherlands that indeed of 375 individuals who wanted to apply for PrEP study, 18 of them, which translated to 4.8%, had hepatitis C, telling us that there is already a significant introduction of hepatitis C also in the HIV negative MSM patient population. That's important because we would treat all co-infected patients because they're maybe easier to identify. There still will be a source of new infections from people who are HIV negative but also already have acquired hepatitis C infection. Next slide. And this is the final slide of the epidemiology section, really looking at the most recent figures from the WHO, which were presented this year in Amsterdam at the Liver Conference. And I think what the first will note is that the number of worldwide estimated hepatitis C patients has even gone down a little bit more, from 80 million up to 71 million. And I think one of the big problems we're facing is that of those 71 million, only 20% have been diagnosed worldwide. So that means that a lot of the people who have hepatitis C don't know their diagnosis. And if you don't know you have hepatitis C, well, then you're not going to be likely to receive therapy for that. So there have to be huge efforts in scaling up testing, in particular in patients at risk for having acquired hepatitis C, to make sure that we can start getting more successful in eliminating hepatitis C. And obviously WHO has been very ambitious in putting out targets of what they want to have achieved in 2030, and indeed they want to have 90% of infected diagnosed, so the gap is still 70%, and really that seems to be the biggest challenge in the coming years. So whereas treatment has transcended into a cure for almost all, I think the big issue here is really that most of the patients with hepatitis C are not diagnosed, and you can see that despite the success rates of therapy, those who started on treatment in 2015 still remains very, very low. It's far away from the 80% diagnosed treated target for 2030 WHO has delivered. Next slide. So let's talk a little bit about natural history. Why do we worry about liver disease caused through hepatitis C? Next slide. Well, the first thing you have to know that there are different genotypes, and although there is only little data suggesting that the course of disease is different between genotypes, there is some data that there may be more fatty liver disease with genotype 3, and there's some specific features of various genotypes, but in the end of the day, the genotype information, which basically says that hepatitis C comes in different virus forms, which can be detected in the lab, is important because not all hepatitis C drugs we have work equally well for all genotypes. And so knowing the genotypes allows to specifically choose a hepatitis C therapy which works against the genotype the patient respectively has. Next slide. Now, when someone gets infected with hepatitis C, around 80% will go on to develop chronic hepatitis C. So that means they remain replicating over 6 months. Patients who have HIV and get hepatitis C infected, they have a somewhat lower probability of curing hepatitis C spontaneously. So it's only around 15% who manage to not move on to chronic hepatitis C. Many of these patients remain asymptomatic for many years, may have slightly elevated ALT, liver enzymes, or even normal liver enzymes, rarely jaundice, and progression of disease is slow. However, there is a specific rate of patients which go on, continue to develop increased liver fibrosis, which then can lead to liver cirrhosis. And of those who have cirrhosis, there is a constant percentage of patients who go on to develop liver cancer. And that's why the reason you want to treat, because if you can treat someone successfully, your risk for cirrhosis and liver cancer can change dramatically for the better. Next slide. In the setting of HIV, unfortunately, progression of liver disease is accelerated. And you see here from 18,000 patients from the Euroceta cohort, first of all, a third of patients have antibodies, 3/4 of those who have antibodies have signs of ongoing replication, really highlighting that hepatitis C is commonly found in HIV patients in Europe. And if you look at the progression to liver death, so liver disease leading to death, you can see that being or having hepatitis C antibodies increases your risk by 9-fold. So you're 9 times more likely to die from liver disease if you have antibodies. And then that increases further if you're also replicating and have RNA detectable. Wasn't the difference between genotypes though. Next slide. Now, most studies have shown that progression of liver disease is closely linked to the development of immunodeficiency. So the lower your CD4 count becomes, the more likely an HIV patient is with hepatitis C to develop significant fibrosis. So the obvious question then was, well, if we give HIV therapy and prevent a drop in CD4 count or even immune reconstitution, is then the course of liver disease going to be comparable between mono and co-infected patients? This was just studied recently in the veterans cohort, and what you see is that even if you are on HIV therapy and have co-infection, you still have a 1.5-fold higher risk of having hepatic decompensation. Hepatic decompensation is something which we call progression of liver disease, where you can develop fluid in your abdomen, so it's ascites. You can develop hepatic encephalopathy or bleedings of varices, which are a production from portal hypertension and the impossibility of blood to stream through the liver and get cleaned as it's supposed to. Next slide. Now, the interesting thing of this paper was when they looked which patients are at the highest risk, it was really, again, patients with a low CD4 count. So once you have a low CD4 count, your risk for cirrhosis is enhanced, and then obviously your risk for hepatic decompensation remains. So having very low CD4 count in the setting of co-infection is bad because that increases your risk of liver disease-relevant events, and also those who are obviously replicating and not well controlled under the HCV regimen also have a higher risk of hepatic decompensation. Next slide. So obviously, in particular, in patient groups where disease progression is worse than in monoinfection, for example, co-infection, treatment seems to be the ultimate goal. Next slide. The problem with treatment, though, was that when hepatitis C was discovered for the first time, that was in 1989, the subsequent regimens which were developed, in particular interferon and ribavirin, were relatively toxic, had to be given over long time periods, 12 months, and even then, the cure rates weren't really very convincing. Once interferon was pegylated so that a slower release form was developed, allowing once-weekly administration, therapy became some easier, but still the toll of, in particular, CNS toxicity was high. A lot of patients developed depressions. Once the direct antiviral medications, just like in HIV, targeting the replication cycle and interfering with enzymes in that cycle, for example, led to much better overall cure rates. And you can see that already in the combination of a first-generation protease inhibitor with interferon and ribavirin. Over 2/3 of patients responded favorably and were cured from hepatitis C. Now, since 2015, we have interferon-free combinations of all oral drugs allowing curing the majority of patients. Some specific cell situations may still require ribavirin, but it has become a rather rare event. Next slide. Looking at the hepatitis C life cycle gives you an imagination of the different steps within the replication cycle where you may interfere and have pharmacological targets for drug development. The main drug classes which have been developed were first the protease inhibitors, which inhibit the activity of the NS3 protease. The protease is needed to prevent processing of HC proteins required for replication. And all these drugs end with the Previr. So the first drugs, telaprevir, boceprevir, you can tell these were NS3 inhibitors because of the ending being Previr. NS5A inhibitors, which are now commonly used in combination with protease inhibitors, are ending with Azir, and then you have the NS5B inhibitors, Buvir, like sofosbuvir or sabavir. Next slide shows you a list of all the different drugs which are currently there, and I've put in black the ones which have been licensed, so you can see we have quite a number of registered and licensed drugs now throughout the world. In green are the ones which were initially there but have been already withdrawn from most markets because better tolerated, shorter treatment durations are available. So if you look at the ones in black are the licensed one, and the red are the ones which are still in development. So you can see there still are some drugs in development. And in green, you see the first drug which are already being withdrawn because of higher toxicity issues or longer treatment durations, or because they were developed in combination with interferon, which we obviously don't give anymore. So there's already drugs which are entering our history. There are current use drugs and some which may enlarge our armamentarium even further. But I think it is of note to say that hepatitis C drugs have been very successful, and that indeed there is little room for even better drugs to be developed. And as such, you will see increasingly messages which just came across today, for example, yesterday from NATAP, that Janssen, for example, announced that they're closing their hepatitis C development program, which reflects that very good drugs have been developed, and for companies it's becoming difficult to develop even better drugs in that area. Next slide. Now, which patients should be considered for therapy? And I think it's very important to highlight that in the guidelines, and this is taken from the EASL guidelines, all treatment-naive and treatment-experienced patients with compensated or decompensated liver disease should be considered for therapy. So it's really now opening up to say everyone who has chronic hepatitis C is a potential candidate for therapy. And yes, if you have very many patients, there may be a prioritization of those with more advanced fibrosis, But in general, everyone should be treated. And there's also, I think very importantly, a sentence which says that people who are at high risk of transmitting hepatitis C, active IV drug users, men who have sex with men with high-risk sexual practices, women of childbearing age, and so forth, as well as incarcerated individuals, all should be treated in order to prevent onward transmission. Next slide. And for all of those who are working in the area of HIV, I think it's very, very important to remember that in the old days when we had interferon and ribavirin, the cure rates were much lower in co-infection. That's one of the reasons why companies were very reluctant to test DAAs in HIV patients, because they felt that these patients may do less well. There were fears of drug interactions. And I think what came out with the phase 3 trials in co-infection, that the cure rates were absolutely superposable to the ones seen in mono-infection. And so now the guidelines say indications for hepatitis C therapy in co-infection are identical to those in mono-infection, and interferon-free regimens are the best options in mono and co-infected patients, which I think is very important to push to have these drugs available for co-infected individuals. And you may also use the same regimens. The only thing you have to look out for are drug-drug interactions, which we'll cover at a later part in this webinar. Next slide, please. Now, one important thing to say is that if you do come up with a decision to have treatment, I think one important thing is that you need to know how high is the viral load, because some of the regimens may be given longer depending on how high your viral load is. So the higher your viral load is, the more difficult it may be to achieve cure, or you may need a more potent regimen or a longer duration of a regimen. So that is an important piece of information. And then, as mentioned earlier, the genotype is important because it will determine the choice of therapy among other parameters. Resistance testing in general is not recommended, although there's some drugs in the US, for example, which are licensed only on the basis of a prior resistance test. This is particularly important for genotype 1A patients for some of the licensed drug, but most of the drugs can be given without a resistance test. Next slide, please. Now, the goal of therapy is obviously to cure hepatitis C. So different than HIV and HPV, where we can give medication, control viral replication, but we really do not achieve cure. Here, we can cure hepatitis C, clearly with the goal to prevent hepatic cirrhosis, so fibrosis, progression, decompensation of liver disease, and the occurrence of liver cancer. And the successful cure of hepatitis C is defined as an undetectable hepatitis C RNA by a sensitive assay 12 or 24 weeks after stopping therapy. Next slide. And what is important, this has been very important also, the discussion about the cost of the drugs, is to demonstrate the clear clinical benefits and increases in survival if you achieve hepatitis C cure. So this is taken from a large collaborative study in several countries, driven by the Dutch colleagues, showing that if you achieve cure, so the negative PCR 24 weeks after therapy, and looked at patients with cirrhosis and their risk of dying from liver disease or developing liver cancer, you can see that those who had a cure did much better, were much less likely to die from liver disease, receive liver transplantation, or to develop cancer. Very strong evidence that treating patients with cirrhosis leads into immediate survival benefit. Next slide. With more and more people being treated, now data is also generated in those who have different stages of fibrosis. And we're also beginning to understand that hepatitis C, just like HIV, is a chronic infection which can cause inflammation. Inflammation in the human being can cause atherosclerosis. If it's along the blood vessels, that can cause cardiovascular events. So what we're starting to see in some of the larger cohorts is that indeed curing hepatitis C, getting rid of that inflammation which is caused by a chronic viral infection, there actually is also a decrease or less occurrence of cardiovascular events in people who were cured for hepatitis C versus those who continue to replicate and have chronic hepatitis C. So the benefit of hepatitis C therapy may be way beyond prevention of liver cancer and liver cirrhosis. It may also help to improve the overall survival by decreasing risk for cardiovascular events, Also, don't forget that hepatitis C can cause insulin resistance, which may cause diabetes, and that may also be lowered after getting rid of hepatitis C altogether. Next slide, please. Now, in the current EASL guidelines, you see that a lot of different combinations of antivirals now exists. Note that some of the ones which were around from the very first phase, like cefoxitin and ribavirin, are even no longer recommended because they have suboptimal cure rates. But I think what is important is that we have, for every genotype, we have options. Yes, the options are a little bit more limited for genotype 2 and 3, but even there we have now several pan-genotypic regimens which we can give. So really, I think it's important to note that for all genotypes, pan-genotypic solutions are available. Next slide, please. So let me show you some of the initial data. This was taken from 4 different trials, looked at 4 different combinations in patients with HIV and hepatitis C who were treated between mostly here 12 weeks, some a little bit longer, and you can see that the cure rates are all above 96%. And obviously, it cannot be much better than that, and is very similar to what has been achieved in similar studies in monoinfected patients. So the wealth of data from clinical trials excuse me, really suggests that cure rates can be achieved in over 95% and that the response rates are not different in co and monoinfected patients. Next slide, please. This is taken from one of the more recent combinations of sofosbuvir and valpatisvir. And again, you can see here, because this is one of the first fixed dose combinations with pan-genotypic activity, you see that regardless of the genotype, all of the patients seem to respond. Next slide, please. And this was true for patients with cirrhosis at baseline, as well as for patients who had failed a prior therapy. So really seemed to work in all patient types. Next slide, please. And I think what cannot be stressed enough is that not only are so many people cured now over 95%, it really comes at a fantastically improved tolerability issue. And I think that's very important in clinic, because there still are some patients who sort of know friends from the old days of interferon and listen to the terrible stories of side effects and depression. This is very different. Once ribavirin and interferon are out of the equation, these drugs are tolerated very well, and you can see from the various trials I showed you, there's hardly anyone who stops therapy because of adverse events. It's on average 0%, just highlighting how well tolerated these drugs are. Next slide, please. This is one of the studies, so I'll focus a little bit now on some of the newer drugs, one which has just been recently licensed, may not be available in all countries yet. It's the AbbVie second generation fixed dose combination of a protease inhibitor called glucopravir with an NS5A inhibitor, probentasvir, and that's co-formulated and given either for 8 weeks in patients who had HIV and hepatitis C but were non-cirrhotic, and then the longer treatment duration, 12 weeks for patients with cirrhosis. So the big difference here is that this is a new regimen which allows shorter treatment durations potentially, and as you can see from the next slide, indeed the overall cure rates were fantastic. All of the patients receiving 8 weeks responded, except one where there was missing data and one patient discontinued, although that one patient returned after stopping therapy and achieved cure. And only one patient had a breakthrough, and that was a cirrhotic genotype 3 patient who was non-compliant. So overall, excellent response rates, and suggesting that we now for the first time have a regimen which allows shorter treatment durations of 8 weeks in co-infected patients. Next slide. The study I'm presenting you now is a little bit more complicated to understand, but I think one of the important things is that there are still little groups of patients which may be a little bit more difficult to treat, and that is in particular genotype 3 patients who have become sort of the more problematic to treat patient group, particularly when they were already prior treated, failed a regimen, and if they had cirrhosis. And in this study, looking at SOFVAL, which is a pan-genotypic regimen that's licensed for 12 weeks therapy in genotype 3 patients, you can see that if patients did not have any baseline mutations which impacted the activity of the drugs the patient was receiving, then 97% achieved cure. But if they did have these baseline, what we call resistant associated variants, then there was a cure rate of only 88%. So that does tell you that there may be a difference in response. And that's why I said in the beginning, although resistance testing is not recommended in most combinations in patient groups, there may be some very small niches like treatment-experienced genotype 3 cirrhotic patients where this may make some sense. And the next slide shows you what you then may do, because most of these patients which are more vulnerable can be rescued by either increasing treatment duration or adding ribavirin. You can see here that by adding ribavirin, a patient with cirrhosis or the baseline RAS, 100% of cure was achieved with valpalatine sofosbuvir plus ribavirin. So I think that does at least suggest that the addition of ribavirin may indeed be very helpful. Next slide, please. Another study with the new AbbVie-GP combination, again a genotype 3 study looking at 12 weeks of GP versus 8 weeks of GP versus what was the prior standard of genotype 3 treatment, which was soft declatosphere. Next slide. And if you look at the overall cure rates here, but before we do that, we'll look at the patients which were included. So it's important to note these were non-cirrhotic patients, so no one had cirrhosis. There was a high proportion of patients with history of injection drug use, so probably a little more challenging patient group to treat. Next slide. Shows you the cure rates, which were 95% for the 12 weeks, 97% for soft declatosphere, and 95% for the 8 weeks. So again, telling us that we may have a shorter treatment duration here, possible also for genotype 3 patients, something we didn't have before. So I think the trend now in modern hepatitis C therapies, development of pangenetic regimens, which may even allow shorter treatment durations, and that may be important in particular patient groups with adherence challenges. Next slide, please. Now, obviously, a lot of people said when these drugs became available, well, can we trust the data from clinical trials? Is real life going to be different? What can we expect? So there are attempts in many different parts of the world, and I just included one slide here from the GECKO cohort, which is a study in almost 1,400 patients from 9 centers, looking at patients from clinics with, obviously a higher distribution of cirrhotic patients, co-infected patients, diabetics, and so forth. And you can see all of these patients respond equally well. Even the 8-week soft litiposphere, which is the other shorter treatment duration regimen we have, worked very well regardless of the risk group the patient came from, suggesting that the trial results are very well transferable to what we can achieve in real-life clinics. Next slide, please. So let's move to drug-drug interactions. Next slide, please. This is something which is obviously important, particularly in patients with HIV as they take drugs which are metabolized by the liver, HIV protease inhibitors and RTIs, and you really have to make sure that no drug interactions exist. There's a wonderful website from the Liverpool University group where you can correspondingly check all drug interactions. Next slide shows you a table format, some of the significant interactions. So obviously green means no issue, yellow may mean more monitoring or dose adjustment, and green and red is not recommended. So in particular with the efavirenz and some of the protease inhibitors like lopinavir and atazanavir, you can see that we have quite some significant interactions, and this is particularly true for hepatitis C protease inhibitors and HIV protease inhibitors, and so then you would have to switch HIV therapy first in order to find a possibility to combine the hepatitis C drugs correspondingly. But do note that, first of all, with the introduction of non-boosted integrase inhibitors, there are drugs which work with every drug like dolutegravir and raltegravir. Also note that some of these protease inhibitors can be well given with declatosphere, litiposphere, and valpalatine, so that means that we do have options for pretty much every genotype and every HIV regimen. Next slide, please. Of note, proton pump inhibitors can impact the absorption of some of the drugs, and there were studies suggesting that if you had no PPI, you were more likely to be cured from hepatitis C. And if you look at the next slide, you will see that this was particularly true for patients who did not take twice daily proton pump inhibitors. So proton pump inhibitors have some caution labeled when you take them with hepatitis C drugs, and it's recommended to take PPI not more than 20 milligrams together with the hepatitis C drugs, but not before or directly thereafter, in order not to impact the absorption of the corresponding HCV drug. Next slide. But it's not only about HIV drugs and proton pump inhibitors. Really, every kind of drug class can cause interactions. This is just one example from the FDA, the drug sort of regulatory authority from the United States, which looked at potential interactions between lipid-lowering drugs, statins, and all kind of hepatitis C drugs. And you can see there's some purple and red boxes where there are either contraindications or where clinically relevant interactions may be expected. And in the next slide, you can actually see that there were 14 cases of rhabdomyolysis, so people who have severe muscle injury, CK elevation that can lead to kidney failure, and that most likely was believed to be an interaction between a lipid-lowering statin and a DA combination. So it is important to check the drug interactions to prevent clinical complications. Next slide. So what to do in DA failure, and I just want to briefly touch upon that. Next slide, because it's very different than in HIV. Many of you are very familiar with HIV. If you fail, for example, efavirenz, you have a K103N mutation, that regimen is never going to work again. Here, people from the IN4 trial who received sofosbuvir for 12 weeks but failed a very small subset of patients were re-exposed to the same therapy but longer, 24 weeks, and they had ribavirin added. And 8 out of 9 patients were cured. So it's different. Even in the setting of resistance, you may still be able to use the same drugs again if you give them longer and with ribavirin. Also telling us that in general, mutations, if they are present at baseline, may be overcome with longer treatment durations or addition of ribavirin. Next slide. And then obviously there have been combinations, and one of them has just been licensed, and this is the Sofvel-Vox combination, which is a fixed dose tablet of 3 different drugs from 3 different drug classes, so NS5A, NS5B, and a protease inhibitor. And they have been studied in patients who had failed a prior DA therapy, so they failed something like sofosbuvir or sofdecladisvir. And if you look at the left-hand graph, you will see these are patients who had previously received an NS5A inhibitor, so the decladisvir or the decladisvir plus soft, and you can see that whether they had mutations or not, and the majority, as you easily can see, had mutations, the cure rates were still very high, 98% versus 97%. So these new combinations from 3 drug classes overcomes mutations and leads to cure when they are treated for 12 weeks. And notably, ribavirin was not added in this mix, so obviously a much better tolerated regimen. Patients who failed sofosbuvir or grozepivir-albisvir, so who had combinations with soft and a PI, you can see that again there was no impact on those patients who had mutations. On the cure rates was 99% versus 100%. So really, these triple drug combinations promise great cure for patients who failed prior therapies. Next slide. And this is another 3-drug combination from combining sofosbuvir, which is manufactured by Gilead, with the Merck combination of grozepivir-albisvir. And these were, again, patients who failed sofosbuvir, sofdecladisvir, or sofosbuvir. And the next slide shows you the overall cure rates in these patients, again showing you that everyone achieved cure. So by combining drugs from 3 drug classes seems to be a future salvage strategy in patients who failed dual DA therapy. Next slide. Let me just briefly touch upon risk of hepatitis B reactivation. Next slide. There was a report from FDA which reported 29 cases. So people who were receiving DA therapy for chronic hepatitis C had a flare of hepatitis through hepatitis B reactivation. Most of them, though, seem to have chronic hepatitis B up front. Next slide. That has led to guideline recommendations that if you start hepatitis C therapy, you should have a hepatitis B serology first, so that in the setting of having also chronic hepatitis B, you may want to think about, if you are having high levels of hepatitis B viral load, that you should then receive hepatitis B treatment in parallel in order to prevent a flare of hepatitis B once hepatitis C is cured. Next slide, please. So let's finish with looking at reinfection and the vision for the future. So the first thing which is important, next slide please, is to remember that yes, you could be cured from hepatitis C, but you can also become reinfected. So there is no lifelong immunity or antibody protection. If you get exposed and you use an unclean needle again, you may be at risk of getting hepatitis C infected again. So that's one important message. The other one is also that after cure, you have cirrhosis, you still remain at a risk for liver cancer. This risk is maybe lower than you had before when you were not cured, but still there is a risk, so surveillance for liver cancer has to occur every 6 months by ultrasound. Next slide. And this is taken from the PROB-C cohort. This is a large cohort in Europe which collects data on HIV-positive MSM who have hepatitis C, and of 606 patients who were documented with the first infection, 25% went on to develop a second or a first reinfection within 1.8 years. So it tells you that, yes, a lot of people got their infection cured or spontaneously got rid of their virus, but then 25% of them got infected again, really telling us that we have to not only think of treatment, but also how can we prevent reinfection in our HIV positive individuals. Next slide. And one of the fascinating stories, and that's what I want to end because I think it's a very, very positive message, is what if we would treat everyone who has hepatitis C? That appears very feasible in the setting of HIV because obviously, like in the Netherlands, you know you have around 20,000 patients. That is 95% of all HIV patients in the Netherlands. You test everyone for hepatitis C. You come up with, in the end, 1,420 patients who are still in care and have chronic hepatitis C. And if you then move on to treat most of them, that's what happened. So they, by January 2017, had 70% already cured. Then you wonder, well, if everyone gets cured, don't we then eliminate the reservoir, and maybe then the number of new infections will eventually change? And indeed, in the next slide, you can see that when they looked at their acute hepatitis C studies and compared 2014 and 2016 enrollment, they saw that the number of patients presenting dropped by 50%, suggesting that indeed the widespread access to hepatitis C therapy and the inclusion of many patients for treatment has led to a decrease in new infections. And obviously the first question someone asked was, well, maybe they just don't have as much sex in 2016 than in 2014, but there was an increase in syphilis cases by 40%, so it was not a lack of sexual activity. And so clearly this is the first study which suggests that if we treat everyone, we may be able to at least downsize the reservoir of hepatitis C and actually start eliminating hepatitis C from these patient groups. Next slide is my summary. So I think what's important to remember is that patients with HIV and hepatitis C have a higher risk of fibrosis progression, underlying why treatment is so important. But remember, hepatitis C is now something which should be recommended for anyone, regardless of fibrosis stage. And if you give therapy, you can use the same regimens as in monoinfection, but remember that you have to check for drug-drug interactions. And clearly, reinfection, though, is something you have to address beyond pure treatment, but elimination in HIV co-infected populations appears targetable. And in the next slide, summarizing just some of the other key issues, I think we should really fight for having access to therapy for all, whether they're treatment naive or experienced, whether they have fibrosis or not, because the benefit of cure goes way beyond the improvement of outcome of underlying liver disease. I showed you the data from the cardiovascular events. I think we're also getting more data on kidney function, diabetes, and so forth, really suggesting that this has a lot of tremendous positive impact, curing patients from hepatitis C. Resistance testing is not necessarily recommended, but can be a factor to be discussed. Unfavorable baseline factors like cirrhosis or genotype 3 infection and previous treatment failure. Drug-drug interactions need to be checked. And then remember to do a hepatitis B serology before starting hepatitis C therapy so that you can see how high the risk is for HPV reactivation. All right, and that's it. And so I'll close here and be happy to take your questions.
Thank you very much, Jürgen, for this interesting presentation. I'm just going back to this slide where I showed you how to ask questions. So you can write down your question if you click on the question field, or you can also raise your hands and raise your hand, and then I will see you and be able to unmute you so that you can speak and Jürgen can hear your question. While you're all typing, to break the ice, Jürgen, I have one question. You mentioned that of all people living with HCV, only 20% are diagnosed. So how to raise this number? What would you suggest for community organizations, for medical community? What can be done to raise this number?
Yeah, so I think there are very many different approaches, and there has been a call for every country to develop a national hepatitis C action plan, which I think makes a lot of sense because you have to sort of see what are the people who have hepatitis C in your country, what are the drivers, and how can you assess them. And that can be very different. So there's, more general screening can be a strategy in what's happening in France, for example, which has a much higher number of diagnosed people. And then there are different approaches, like in the Australian setting, people are using, mobile street trucks going to the community, so you don't have to go somewhere. People are also coming to where you are, offering testing. The question is, does anyone who has elevated liver enzymes, should he be sort of at least considered as a candidate for hepatitis C testing? And I can tell you, for example, for Germany, that's one of the big issues, that we don't have a lot of guidelines on who to test, or we also have no official reimbursement for testing in people who have elevated liver enzymes, where I think would make sense. But I think it also comes to the simple point of asking people who come for medical care whether they have ever used or shared needles, and things like that, and then to offer a test correspondingly if there is a risk factor which could, hint that transmission may be possible.
Okay, thank you. There's one question that I received just in writing. I will just read it out loud for you. Do we have any studies regarding the side effects between different drugs? What if I have to take more drugs at once, like for HIV and HCV?
Yeah, so we have really very good data from a lot of clinical trials where people were on HIV drugs and hepatitis C drugs. And it really didn't look as if we had more discontinuations in these trials. So people with co-infection stopped just as low numbers, less than 1%, as in mono-infection trials. And I think what we shouldn't forget is that these therapies are on average between 8 and 12 weeks. So that's such a short time. There are some, minor side effects like headache, or some of the PIs can cause a little bit of diarrhea, and there's some sleeping problems which have been reported. But on average, the tolerability is really fantastic. And I can tell you, because we have treated now over 300 patients here in our own cohort, the overall tolerability has been just fantastic.
Then there was one question regarding the comparison between branded and generic medication regarding their effectiveness. Can you?
Yeah. So there has been really great work, in particular in collaboration with Andrew Phillips and the Liverpool group, who specifically were able to measure and look at the generics, whether they contained real substance. And for those generics which were believed to be produced in the right way, and were the compounds which were labeled were also present and detectable, the cure rates, and they have been presented at various meetings, were also all on the average above 94, 95%. So it looks as if the cure rates under generics is absolutely the same. There has been one report of a fake sofosbuvir bottle which popped up somewhere, so that's obviously one of the big concerns. Are there going to be fake drugs circulating? And I've only seen one report on that. All the other reports, in particular those who were in programs where they do sort of control, and that's one of the discussion points with WHO, could there be, like, just like with HIV drugs, which undergo a quality testing, whether this is real stuff and so forth. that should be broader implemented to make sure that the generics are all containing valid, quality approved drugs. But in the end of the day, all the data presented so far suggests absolutely similar cure rates.
And then the last question that I have on my list, asked by participants in advance, was it's more related to prevention, but maybe you can still answer. What are safer sex messages for those living with active HCV infection and people who have sex with HCV positive people?
Yeah, so I think in the era of being undetectable for HIV when you receive successful HIV therapy and therefore not being infectious, and the lack of using condoms, obviously when you have hepatitis C, that is something at least to consider, because clearly infections have been described by unprotected anal intercourse. Clearly there is a hint that blood-blood contacts, so anal intercourse with bleeding, sperm-blood contacts, fisting, use of sex toys, and don't forget that particularly in group sex events, when one person fists person A and then with the same hand fists person 2 or 3, he may have blood from person A, and although he may not be infected himself, but can then transfer blood from person A to person 2 and so forth. And so clearly events with multiple sex partners have been increased with a higher likelihood of transmitting hepatitis C, and then anything which involves potentially blood-blood contacts has been associated with a particularly high risk. I think what we shouldn't forget to say is that in the era of chemsex, a lot of injection also now occurs, and in order to increase intimacy and enhance sexual experience and sensation, drugs are very often used together or slammed together, and obviously sharing needle can then also be a source of transmission. This also counts true for cocaine snorting through the same device. So clearly, make sure that your sex toys you use are clean and only used by yourself, and also make sure that you use needles which are clean and don't share.
Okay, thank you very much. If you have any other questions, it's your chance now to raise your hand or to write them down. If this is not the case, then Jürgen, thank you very much again for your time and for the excellent presentation.
All right, and pleasure.
I wish you all a good day.
Thank you.
Bye.
Tschüss, bye-bye.